Now we are fortunate to have a new speaker with us. So a warm welcome to Aljona Kurbatova. Aljona is head of the Center for Drug and Infectious Disease Prevention, National Institute for Health Development in Estonia. As the head of the Center for Drug and Infectious Disease Prevention, she is responsible for development, coordination, and financing of health and social services in the field of drug use, HIV, and tuberculosis prevention, as well as implementation of national and international cooperation projects. Her work includes designing, services for people who use drugs and/or are living with HIV. We look forward to listening to you, Aljona. What should you know about synthetic opioid preparedness?
Sorry, can I have the clicker? This one? Yeah. Okay. So I'm very happy to be with you today here, and we're going to be talking again about synthetic opioids. And in recent years, new psychoactive substances, novel substances have been increasingly causing harm all over the world, but essentially, synthetic opioids, which are also a part of NPS, are not new. They are not novel. They are well known. They are used for a long time in medicine, quite effectively. And there are a lot of people who have benefited, especially in cancer care, from, for example, fentanyls, which are now causing so much harm. And it's not until Northern America started to suffer due to synthetic opioids that we started to think and talk more on that issue. But in reality, there have been smaller outbreaks in other countries. And Estonia is a country that almost 20 years now has had to struggle with synthetic opioids. And for a very long time, nobody really understood, I think, what we were talking about, because a small country, quite irrelevant in the big picture, country somewhere on the border of Russia, a wannabe Nordic country. We want to be a Nordic country, but we're stuck somewhere on the way there. And so we felt quite alone. And it saddens me that we're not alone anymore, but it's also good that we can finally talk about the experience, and hopefully what we have experienced will also be beneficial for the countries that are not yet in the situation when they have to deal with synthetic opioids. So I will start with a story about my own country and how synthetic opioids fit into the picture, and then we can look at the wider view on how to be better prepared for synthetic opioids. And the story about Estonia, it starts in the end of 90s, so bear with me, it's a long story. And end of 90s, young country, drug issues are not really relevant on a political level. At the same time, the situation socially is quite difficult. And injecting drug use is on the increase. A lot of other social problems are on the increase. People who care, they start to form first harm reduction organizations. They start to put out first services out there. People who don't care, they just don't care. And since at that time, it's the problem of heroin and opium poppy use is mostly affecting Russian-speaking population of our country. On political agenda, it remains low. So we reach year 2001, and people who care are really worried because we have one of the highest prevalence of injecting drugs use in the region. We have already officially concentrated the HIV epidemic among people who use drugs, and a lot of other problems. So again, people who worry, they think it cannot get any worse because we see people as young as 15 years dying from overdoses, and people who don't care, they still don't care. Because those are mostly people who do not speak for themselves who are dying. And then we reach year 2002, and people start dying in even greater numbers. So if you have a situation when you've basically reached a bottom in in every sense how it can get so much worse. And in 2002, Estonian drug market was first flooded with fentanyl. And at that time, in a situation with poorly developed harm reduction and treatment services, it was quite unexpected. And nobody really understood what happened, but we had our first wave of synthetic opioid-related deaths that took away also a lot of very young people. And due to this lack of preparedness and timely action, it actually took a lot of time to understand really what is happening. Why it happened, there isn't a good explanation, so I don't have any scientific articles to quote. But what people working in the field, in police forces, have said later on is that Estonia, being a small country on the end of supply chain, in the time when we had a shortage of heroin supply from Afghanistan, and with well-developed local chemicists and neighboring countries' chemicists who quickly offered a solution for a market in trouble and the market with very high demand for opioids. And that was just a coincidence in a way. An unfortunate coincidence, but it happened nonetheless. But what happened really is that people dealing with opioids, they realized how much more profitable synthetic opioids actually are. The quantity is smaller. At that time, the scheduling issues were completely different. It was not so well known, not so well regulated, not so well detected. Forensics were lagging behind in terms of synthetic opioids, etc. So it was much easier for supply to provide the offer and get the benefit, because the market was there. There was a large number of opioid users who were looking actively for the substances to use. And at first, of course, the market was overflooded by fentanyl without people really knowing that it's fentanyl. They thought that they were buying heroin. They used it as they were used to use heroin. And that's why in 2002, we had this first really significant wave of overdose-related deaths. And what we saw next was a heavily supply-driven market reformation. Heroin could have come back, but it was not allowed to come back. And in a small country, it's quite easy to achieve that. In bigger countries, you have different processes, but you may have quite similar considerations behind that. And also for people who started to use synthetic opioids instead of opioids, because it's a much more potent drug, if you have the choice. So going back to a lower potency was also something that was questioned a lot. And as you can see from the graph, which I am not really going to go into the detail, is that since that time, every year or every second year, a new variation, later on analogs of fentanyl were introduced. And every time a change occurred, and every time we're not prepared for that change, we see again the spike of overdose-related deaths. And from that time until very recently, up to 90% of all overdose-related deaths in Estonia have been connected to fentanyl and other synthetic opioids. So now that this affects more countries than ours, why it's so important to talk about it? It's something that we back then, and I think a lot of us even now don't really understand, is that synthetic opioids are so much more potent than the opioids that we know and love from the old times. And if it would be just fentanyl as a one substance, maybe that would make things easier. But we're looking at a very high number of fentanyl analogs, fentanyl derivatives, with core fentanyl, again, not really a new thing, being so much more potent than the fentanyl that initially came to the market, that people who are very experienced and very skilled in opioid use are not getting it right. So it was a colleague of ours who now works in harm reduction, who was using opioids back when it started, said that in that first year he overdosed 4 or 5 times. And he still don't understand why he's alive, because most of his friends are gone. But even then, there was this knowledge among users themselves that maybe we should be a bit cautious, it's something different, let's just use less. And even people who used less were dying because the difference in potency was so tremendous. And what are the implications, which we were not ready for then, is that if we look at the issues related to synthetic opiates, and now we have more than just fentanyls. In recent years, we also have isotretinoin, for example, and some others, is that drug services are not prepared. In theory, everything that works for opioids, for addressing opioid use, works for synthetic opiate, but does it work exactly the same way? So services were unprepared, people were unprepared, they didn't have the knowledge, and the national responses, at least nationally funded responses, they tend to be rigid. It takes us time to decide to change something, to approve funding for doing things differently. In better countries, it might take months, but it's really epic speed. And some countries, it may take years. You have to adapt a new policy, you have to adapt a new national budget, and so on. So it takes a very long time if you don't have already procedures in place to start doing things differently. And synthetic opioids, they don't wait. The mortality rate goes up as soon as they hit the market. So what were the implications at that point? Do we need as much naloxone for emergency services? People didn't know. So at some points, actually, emergency services were depleted from naloxone stock, and we didn't have a take-home naloxone program at that point. We did have opioid agonist treatment, but the therapeutic doses, average doses promoted in the international guidelines just didn't seem to be as effective with people with fentanyl dependence as with heroin dependence. It did work, but it just didn't seem to be dependent. So it was a constant, trial on how to change the doses, how to combine. Can we prescribe benzodiazepines with the methadone if person is misusing fentanyl, etc.? Needle and syringe exchange. We talk about a drug with a shorter half-life. People started to inject more frequently, which made them more vulnerable, but also implied that needle and syringe services needed bigger stock, different syringes, and anybody who has inside view in how governments, for example, purchase their stock, they might also know that it, again, takes a very long time to get the appropriate stock if you don't have it plans already. So all of those things had to be learned on the go, which year after year cost us a very high number of lives. Another thing is that the user groups were also not only people who inject drugs, but fentanyl was laced at some point to very different other drugs. We found amphetamine laced with fentanyl. We even find some cases of cannabis laced with fentanyl. Why? Nobody knows, but that happened. And how to bring this awareness of the situation to not only people who know that they're at least using opioids, but they don't know that they are synthetic, but also to people who may be using other drugs and have never associated themselves with opioids. So a lot of things had to be learned, and I think that even now, 20 years later, when we have North America in a situation quite similar, but having been hit with synthetic opioid crisis when they already had established services, which we did not have back in the same time, and the origin of the crisis being somewhat different, we still don't really have those preparedness procedures in place. Yes, of course, we still argue about the basics of drug policies within the countries, like the principle of human rights, etc. So perhaps for people, there's no time to talk about preparedness, like for natural disasters. But in reality, most of our countries don't really have good plans in place on government level. People who work in community probably know better, surely know better. But on governmental level, we almost never have the plan in place what to do if the drug market changes like that versus the drug market changes like that. And again, our own experience says that when in 2017 and 2018, after several spikes and the introduction of different analogs of fentanyl, the situation started to even out, and also law enforcement reoriented their work from punitive methods to be oriented more towards really to stop large organizing crime, not to concentrate on people who use drugs and finding them. We saw the change. But what we also learned is that it's not only the services. We have talked today a lot about decriminalization, about basic human rights, and also there was a very important point about arbitrary quantity, small quantity, which goes under the possession as versus to already large quantity, which usually is still a criminal offense. So what happened with synthetic opioids and why it was important not only to move forward with existing harm reduction services or develop new harm reduction services, but also to review how law enforcement is looking at the situation, is that because of its potency, the amount of fentanyl or any other synthetic opioid the person needs for personal use for a day, based on majority of legislation in countries that distinguish between small and large quantity, almost always falls under large quantity. So people who were dependent or used synthetic drugs, synthetic opioids, were disproportionately punished for the same offenses, essentially, as compared to people who use cannabis, people who use amphetamines. And even police officers said, we don't want to do that, but the law is law. The law is very clear, and if we start to treat them differently, then we will have other user groups whom we also have to treat differently. So it was a kind of a worldview-changing event for us, let's just say. And in 2016, for example, when we also reviewed our scheduling procedures to make it for police for it to be easier to confiscate fentanyls, the police also did an analysis, retrospective analysis on the offenses committed by people who use synthetic drugs. And they, for example, found people who have been detained by police as many times as, I think 99 was the highest number within 10 years, with a person spending most of those years in prison. So those 99 times were fit in a few years that he was actually free, without no results that they would have expected from that. And that was the point also when police said, fine, we will not anymore prioritize even the fining of the people who use drugs. They participated very actively in elaboration of law enforcement arrest diversion programs to be able to put their effort more on actually containing synthetic opioids on the market. And here we saw this combination effect. So stronger harm reduction, adjusting your opioid substitution treatment, your naloxone, but also changing the previously punitive approaches. We did have drug use decriminalized since 2002, but since there was still an administrative fine and people quite often couldn't pay the fine, so at some point they might still be, unfortunately, also arrested. And what is the main learning? One of the main learning points is that after fentanyl was mostly contained on the market, demand didn't disappear. Police, for example, was very, once they had already closed the network, not before, but once they had already closed the organized crime network, so they knew that at least for a time being, fentanyl will no longer be in the same amount available on the market, they said to treatment services, no, everybody will come to treatment. That you should be ready from tomorrow, everybody who were using fentanyl, they will come to treatment because they have no access to fentanyl anymore. No. What we had was alpha PVP, which came practically within a month, and again, we saw this supply-driven market change where people were actively seeking for the substances, and people who previously we didn't even consider could transition from synthetic opioids within weeks to amphetamine-type drugs or caffeine-type drugs actually did that, to preferring that to, for example, services. So again, we have this constant. It was better when we had heroin, but then we had fentanyl. We got used to fentanyl. You get used to everything, probably. Whether you should is a completely different topic. And now that we still don't have fentanyl back in the same amount, people are saying all those mixtures, all those diluted fentanyls mixed with methamphetamine. We don't have drug checking services in Estonia, by the way. So that's, people die less, but the harm is not less. So we have right now the situation where we are in between. So we see from time to time fentanyl coming back, but people have lower tolerance because they haven't had it for a while. So we're constantly waiting. Does it come? Does it not come? Does it? Where are we right now with it? Or what should we do? How prepared we are? And those are the messages that we now have. Is that, for example, police doesn't wait anymore for an official confirmation. As soon as they get the information that it's possible that fentanyl is available back on the market, they put out an informal alert, which we as a national institute can forward to the service providers who then work with the community. We do have the stocks available if needed of syringes, of naloxone, etc., but it's still a pretty tight fit. I mean, we don't really know what will come. And if it's not fentanyl, but it's something else, if it's only carfentanil, how will that change? And that's why we need to put more effort in actually preparing ourselves for all those scenarios and hope that they will not realize themselves, but at least that we have a plan. Because in our case, the formula was quite easy. We didn't know, we were not prepared, and a lot of wishful thinking. I mean, this too shall pass. I mean, nobody else has that. I mean, nowhere else that happens. So why should we be bothered? It will come and go. So why? But then you have a loss of life, and then you're accountable, and then you have to ask yourself that if I weren't that wishful in my thinking, maybe people would be still alive. And again, just to reiterate that it's very important that we have a warning system. Some of the countries in the region have a very good warning system, but a lot of us don't. We don't really incorporate information from people who use drugs actively in national network of information exchange. We might passively, and I'm speaking from a government perspective right now, we might passively give out information, but the active exchange tends to still be quite poor, and therefore the impact is not sufficient enough. And it has been talked about today a lot in concern to other drugs, but with synthetic opioids especially, drug checking is crucial, because impact on mortality in comparison to other drugs is just so much higher. And if you in your country have even the first signs of synthetic opioids, it should increase the push for drug checking services if you do not still have them. And of course, being prepared. What can we do to be prepared, and how can we use our own experience to help others be better prepared? And now the commercial part of the presentation is that 5 countries together with the Correlation Network, we have a European Commission-funded project that aims to help to increase this preparedness for synthetic opioids based on the experience by the countries who are already affected. The scientific literature is starting to come in, but it's still not so much of it that we can draw enough conclusions on what is evidence-based. But there are a lot of practical tips which we know do not make it any worse, even if the positive impact may not be as high as we would like it to be. So what we are doing right now is that we are collecting all that information. We are looking at the experience in North America within this group of organizations. We are looking at the experience from Estonia. We also have a report published on that, and we will shortly publish a report on North American experience, on the overall preparedness in the region. And we're also consolidating the information from different sources on what are the practical tips available. So if you don't have an naloxone program, that you should have an naloxone program in place, is that if you have fentanyl problem or synthetic opioids program, is that you need more naloxone than you think you need based on your experience with opioids. It's what kind of syringes you might need. How fast do you need to roll out the program? So simple things like that, which might seem like business as usual, but we don't often really think through ahead of the situation. And we hope that this will provide also a little bit of help for countries who, on government level again, who care and who want to be better prepared for the situation. And you can always point the finger at us and say that if you don't, you can be the overdose-related overdose death capital of the region. And Canadian and US colleagues asked us, once the situation started to worry, what advice do we have? And looking from Estonian perspective, a small country, 1.3 million, with a harm reduction system, underdeveloped in comparison to Canada, clearly, is that what can we offer, for example, to each other when we are so different? Our state prosecutor even said that no matter what we do, it will not work in US because we're so different as countries. But there are a lot of things that do work. Those simple things, even like simple things, how to talk to people who use drug, how to use, not use is a bad word here, how to involve peers in really taking care of each other, in engaging their relatives in naloxone trainings, for example. Because with amphetamine-type drugs, you will not have the situation when you may actually rely on your mother to save your life. So it's a difference here. And it's very important that if we have good ideas even, or we have some experience, even if there's not a scientific article on it, that we exchange that, because each one of those tips can actually save somebody's life. And if it can, then that should be done. So I guess that would be all from me on these topics.